Welcome to The Deep Dive, the show that's all about extracting those vital nuggets of knowledge from complex topics, helping you become truly well-informed quickly. And kind of in the spirit of our companion show, BodyTalks, today we're diving deep into a condition where the body really does communicate in, well, unexpected and often agonizing ways. Endometriosis. Imagine experiencing a level of pain so profound, so utterly debilitating that it routinely forces you to miss work or school, that it makes intimacy unbearable or even makes simple daily tasks feel like monumental challenges. We're not talking about typical discomfort here. We're talking about chronic, life-altering pain that is, unfortunately, often dismissed or normalized. And this is the reality for millions living with endometriosis, a condition estimated to affect a staggering 10% of reproductive-age women and girls globally. That's roughly 190 million people worldwide. It's huge.
It really is a staggering number.
So, our mission today is to go far beyond just the surface-level information. We're here to extract those key insights, the surprising facts, the nuanced understandings that will give you a truly comprehensive grasp of this complex disease. We'll explore everything from its fundamental definition and, well, truly perplexing theories about its origins, to its profound and often devastating impact on individuals' lives, the challenging journey to diagnosis, and the evolving landscape of treatment pathways. We really aim to not just inform you, but to kind of unravel the intricacies that make endometriosis such a unique and, I suppose in a medical sense, a fascinating puzzle.
And that unraveling, that's precisely why this deep dive is so crucial. Given its immense prevalence and the significant individual and societal burden it imposes, understanding endometriosis isn't merely about acquiring medical knowledge. It's really about fostering a deeper level of awareness, empathy, and challenging those long-standing misconceptions that have plagued those affected for far too long. We hope to equip you, the listener, with the essential information to recognize its, well, insidious signs, comprehend its biological mechanisms, and ultimately appreciate the incredibly challenging journey of those who live with it every single day.
Okay, so let's start right at the very foundation. What exactly is endometriosis? At its core, it's defined as a condition where tissue that is similar to the lining of the uterus, what we medically call the endometrium, begins to grow outside the uterus. Now, for those who might need a quick refresher, the endometrium, that's that remarkable dynamic tissue lining the inside of your uterus. Each month, it meticulously grows and thickens, preparing this soft, nutrient-rich bed for a potential fertilized egg. If pregnancy doesn't happen, this lining then sheds, which is, what we experience as a menstrual period.
And here's where the critical distinction and really the core of the problem emerges. This endometrial-like tissue and the like is important. It doesn't just mimic the appearance of normal uterine lining, it behaves like it too.
Yeah.
So with each menstrual cycle, under the influence of hormones, it thickens, it breaks down, and it attempts to shed or bleed. But, and this is the key because it's growing outside the uterus, there's absolutely no natural exit pathway for that blood and tissue. It's trapped inside the body.
Right. It has nowhere to go. And the consequences of this trapped, misplaced tissue are profound and, well, they cascade, don't they? This bleeding inside the body triggers what's called a chronic inflammatory reaction. Imagine your body constantly reacting to an internal irritant month after month. Over time, this inflammation leads to the formation of scar tissue. We refer to this as adhesions or fibrosis.
Exactly. And these adhesions can literally act like superglue, causing pelvic tissues and organs like your bowels, bladder, even your ovaries to stick together. They become bound down. This creates a painful, often distorted anatomical landscape that can severely impact organ function and, crucially, nerve pathways, leading to chronic pain signals.
Precisely. And when this endometrial-like tissue specifically involves the ovaries, it often forms these distinct cysts known as endometriomas. You might hear them called chocolate cysts.
Yes, that's the colloquial term. It's due to their characteristic dark, tar-like appearance, which is essentially old, trapped blood. The presence of endometriomas on imaging, like an ultrasound, can often be a strong indicator of endometriosis. Though it's important to remember, their size or number doesn't always correlate directly with the severity of a patient's pain.
That's a really key point. So they're a sign, but not the whole story regarding symptoms.
Exactly. A clear sign of the disease's presence on those organs, but just one manifestation of a much broader condition.
Okay, so where does this tissue typically show up? When we talk about where it chooses to, well, set up camp, the pelvic region is by far the most common location. We frequently see it on the ovaries, the fallopian tubes, and the ligaments that provide structural support to the uterus. like the uterosacral ligaments. It's also often found on the lining of the pelvic cavity itself, that membrane called the pelvic peritoneum. And it can appear on the outside surface of the uterus, or even in those spaces nestled between the uterus and other organs like the rectum or bladder in what's known as the rectovaginal septum. These are the, let's say, expected, albeit still painful, sites.
The usual suspects, if you will.
Right. But here's where this condition truly starts to reveal its mysterious and, frankly, surprising nature. While the pelvis is common, this tissue can spread to less common and even incredibly rare locations throughout the body. We can find it on the bladder, the intestines, the rectum, the cervix, the vagina, or the vulva. And sometimes it can even infiltrate the myometrium, which is the actual muscular wall of the uterus itself. That's a specific condition called adenomyosis, which often coexists with endometriosis, but is technically distinct.
Yes, an important distinction. Adenomyosis is sort of endometriosis within the uterine muscle wall.
But the truly astonishing part, the bit that often takes even seasoned medical professionals by surprise, is that in rare, albeit documented cases, this endometrial-like tissue can be found far, far beyond the pelvis, places like the diaphragm or even the lungs. The implications for symptoms, as you can imagine, are truly unexpected.
Indeed, the phenomenon of extrapelvic growth, it profoundly underscores the complex and systemic nature that endometriosis can sometimes take. For instance, if the lungs or the diaphragm are involved, individuals might experience symptoms like chest pain, shortness of breath, or even a cyclical cough or hemoptysis that's coughing up blood that lines up with their menstrual cycle. These symptoms can be incredibly confusing for both patients and clinicians, often leads to misdiagnosis or significant delays as doctors investigate, pulmonary or cardiac causes before thinking of endometriosis. It really challenges our traditional understanding of a gynecological disease and highlights its potential to impact almost any part of the body.
It really does broaden the scope, doesn't it? And as we mentioned right at the top, endometriosis is far from being a niche or rare condition. It affects roughly 10%, maybe even more, or approximately 190 million of reproductive-age women and girls globally. This is a staggering number, comparable in prevalence to other well-known chronic conditions like diabetes or asthma.
It's incredibly common.
And while it's typically diagnosed in individuals in their 20s and 30s, the condition itself can actually start much earlier, sometimes even from the very first menstrual period, menarche, and it can persist right up until menopause.
What's particularly important to emphasize here is that endometriosis truly affects individuals regardless of ethnic origin or social status. It highlights its widespread and indiscriminate impact across diverse populations worldwide. There's no group immune to it. While symptoms often, though not always, improve after menopause due to the natural decline in estrogen levels, it's not a guaranteed cessation of the disease. In some instances, symptoms can reactivate, especially if hormone replacement therapy, or HRT, is used. Introducing external estrogen can re-stimulate any dormant endometrial-like lesions. So that nuance is really vital for long-term patient management and discussion, especially around menopause.
Absolutely. Okay, let's unpack one of the biggest scientific puzzles surrounding endometriosis. We now have a clearer understanding of what it is, this rogue tissue growing outside the uterus. But here's where the mystery truly deepens and, frustrates both researchers and patients alike. The exact cause of endometriosis is still largely uncertain. And perhaps even more frustratingly, there's currently no single known way to prevent it. It's like trying to solve a complex biological crime without knowing the motive or having all the forensic evidence.
That lack of a definitive singular cause is, as you say, a monumental challenge for research. It's also a profound source of frustration for patients who desperately seek clear answers and a straightforward path to understanding their condition. If we don't definitively know the why, preventing and truly curing the disease becomes immensely difficult. However, it's not for lack of scientific inquiry. Multiple theories are being rigorously explored, each shedding some light on potential biological pathways. They're helping us piece together this intricate puzzle, even if no single theory seems to explain every single case. It's likely multifactorial.
Right, a combination of things. So the leading theory, and probably the one you'll hear discussed most frequently, is called retrograde menstruation, essentially a backwards flow of menstrual fluid. This theory posits that instead of exiting the body entirely, menstrual blood, which naturally contains endometrial cells, flows backward through the fallopian tubes and spills into the pelvic cavity. The idea is that these cells then get deposited outside the uterus, where they can implant, establish a blood supply, and begin to grow into lesions.
Well, it's certainly the most prominent and widely accepted theory. It doesn't on its own, fully explain all cases of endometriosis. And this is where the deeper scientific questions really emerge. We know that a significant number of women, probably most women, experience some degree of retrograde menstruation, but only a fraction, that 10% or so, actually go on to develop endometriosis.
So it can't be the whole story.
Exactly. It strongly suggests that while retrograde flow might be a necessary condition for some, maybe even many, it's certainly not sufficient on its own. It points us towards a complex interplay of other factors, perhaps a genetic predisposition that makes some individuals more susceptible.
Right, like a family link.
Yes, or a unique immune response that fails to effectively clear these misplaced cells, or perhaps even environmental triggers we're still striving to identify. It's like having all the ingredients for a complex recipe, but only some individuals possess the unique spark or combination of factors needed to actually cook the disease, so to speak.
That's a great analogy, and that connects nicely to those other potential factors. So let's move to theory 2. Cellular metaplasia, or transformation. This theory proposes something really fascinating. That cells which are already outside the uterus undergo a change. They transform from one cell type into endometrial-like cells and then start to grow. So the body's own existing cells can essentially morph into this problematic tissue. That's quite an internal identity crisis.
It truly is, and it speaks to the remarkable and sometimes problematic plasticity of our body's cellular machinery. It's quite incredible what cells can do. Within this broad theory, we have a couple of sub-theories or variations. One suggests that transformed peritoneal cells, those cells lining the inner side of the abdomen, might, under the influence of hormones or specific immune factors, transform into endometrial-like cells. Another intriguing aspect is embryonic cell changes. The idea here is that dormant embryonic cells, which are leftover cells from early developmental stages, might be stimulated perhaps by factors like estrogen during puberty to differentiate and mature into endometrial-like growths. This theory is particularly compelling for explaining lesions found in unusual or distant sites, where retrograde menstruation seems less likely to be the sole explanation, like those lung lesions we mentioned.
That makes sense for those outlier cases. Okay, and then there's theory 3, the role of stem cells. This concept posits that certain stem cells can give rise to the disease initially. What's particularly captivating, and maybe a bit alarming about this theory, is its proposed mechanism of spread. These stem cells, or maybe the disease itself, can then travel through the body via blood and lymphatic vessels. This spread, as you pointed out earlier, is strikingly similar to how certain cancer cells can metastasize to distant sites. It really could explain how those truly remote lesions form.
It's a truly fascinating insight, offering a potential explanation for the, well, systemic nature of endometriosis in some individuals. If stem cells are indeed involved in the disease's genesis and spread, it definitely broadens our understanding beyond just localized pelvic growth. This capability for mobile stem cells to establish colonies in unexpected tissues, like the lungs or diaphragm, suggests a more pervasive biological process than previously imagined. And it really shifts our perspective on how we might need to target interventions in the future.
Okay, theory 4 is a bit more direct, perhaps less mysterious. Surgical scar complication, or direct implantation. This seems fairly straightforward. It occurs when endometrial cells directly attach to scar tissue from a surgical incision made in the abdominal area, for instance during a C-section or maybe another abdominal surgery like an appendectomy.
Exactly. It's essentially a direct transplantation of those cells from the uterus, or perhaps floating in the pelvic cavity, to a new, unintended location during the surgical procedure itself. A very clear, albeit less common, pathway for the disease to manifest itself in a localized area, particularly following gynecological or abdominal interventions. It definitely highlights the importance of meticulous surgical technique to try and prevent accidental cell transfer.
Right. And connecting back to that idea of widespread dispersal, theory 5 is endometrial cell transport. Here, the thinking is that the blood vessels or the tissue fluid system, meaning the lymphatic system, might literally move endometrial cells to other parts of the body. This offers another compelling explanation for those rare extrapelvic sites we discussed, those tiny cellular travelers moving through the body's highways, setting up camp in the most unexpected places.
Absolutely. This theory provides a plausible biological mechanism for the truly distant lesions, such as those found in very rare instances in the brain or even on the skin. It indicates that these endometrial cells can indeed become highly mobile within the body, leveraging the circulatory and lymphatic systems to reach remote destinations. This mobility is a significant aspect of the disease's perplexing nature.
Definitely adds to the puzzle. Finally, theory 6 points towards an underlying immune system condition. This hypothesis suggests that a problem with an individual's immune system might make the body unable to recognize and destroy endometriosis tissue. So, in essence, the body's natural defense mechanisms, which are normally incredibly adept at identifying and clearing out rogue or misplaced cells, might fail. They don't properly identify or clear away these endometrial cells, allowing them to establish themselves and grow unhindered.
Right, a failure of surveillance, so to speak. And underpinning many, if not all of these theories, host, is the pervasive and complex influence of estrogen. Endometriosis is widely recognized as being dependent on estrogen. This means that the hormone tends to increase the inflammation, stimulate the growth, and exacerbate the pain associated with the disease. Estrogen acts like fuel to the fire, nourishing these lesions.
But it's not straightforward, is it?
No, exactly. The relationship between estrogen and endometriosis is incredibly complex and nuanced. For instance, the absence of estrogen, such as during menopause or with certain hormone-suppressing medications, does not always mean the absence or complete resolution of endometriosis. This suggests that other factors, or perhaps metabolic pathways within the lesions themselves, can sometimes maintain the disease, even when systemic estrogen levels are low. Understanding this nuance is absolutely critical for developing truly effective and comprehensive long-term treatments. It's not just about turning off the estrogen tap.
That's a really important point for managing expectations with treatment. Okay, so we've talked about what endometriosis is and the, frankly, bewildering theories about how it starts. But what does this all practically mean for someone experiencing it? For millions, the most common symptom and often the most debilitating is chronic pelvic pain. And this isn't just a minor ache. It's frequently described as severe, life-impacting pain, particularly pronounced during menstrual periods, that condition we call dysmenorrhea. And for you, our listener, we really cannot emphasize this enough. This pain is far worse than usual. It extends beyond normal cramping. While discomfort is part of life, normal menstrual cramping, while sometimes inconvenient, should generally be tolerable. It should not require someone to miss time from school, work, or normal activities. If your pain is consistently dictating your life, that is a huge red flag.
That distinction is absolutely vital, host, because for far too long, severe menstrual pain has been normalized. Individuals are often told, oh, it's just bad periods, or you just have a low pain tolerance. Yeah. But the pain associated with endometriosis isn't just a minor discomfort you can push through with some ibuprofen. It may start before a menstrual period and last for days into it, disrupting an entire week or even more of a person's life, month after month. And critically, it often becomes worse over time. This isn't static. It indicates a likely progression of the disease and an increasing burden on the individual, rather than just a transient or unchanging issue. This worsening pattern is a key indicator that something more significant is at play.
Yeah, that progression is a key feature. And beyond that generalized pelvic pain, there are a host of very specific and often distressing pain experiences that characterize endometriosis. The painful periods, dysmenorrhea, often manifest as this deep, aching lower back and stomach pain, frequently radiating into the abdomen and sometimes even down the legs. But it also includes things like pain with sex, medically termed dyspareunia. This can be experienced both during and after intercourse, profoundly impacting intimate relationships and, well, overall quality of life.
And the reach of this pain isn't just limited to reproductive functions, which is important to understand. Many individuals report pain with bowel movements or urination, especially common just before or during a menstrual period. This can be agonizingly intense when using the bathroom, particularly if the endometrial-like tissue has grown directly on the bladder or the intestines, physically impinging on these organs or causing inflammation around them. And beyond the cyclical pain that ebbs and flows with menstruation, there's also the pervasive challenge of chronic pelvic pain. This persists outside of periods, making it a constant, sometimes inescapable struggle for many, and profoundly impacting their daily existence, their work, their social life.
And the symptoms truly don't stop with pain, do they? Other significant issues include excessive bleeding. This can manifest as incredibly heavy menstrual periods, sometimes requiring frequent changes of pads or tampons maybe every hour or two, or even bleeding between periods known as spotting or intermenstrual bleeding.
Right, and for a significant number of individuals, endometriosis is first identified when they are struggling with infertility. For some people, endometriosis is first found during tests for infertility treatment, becoming the unexpected and often unwelcome answer to their struggles to conceive.
That must be a difficult way to find out.
Absolutely. And beyond the localized pain and reproductive challenges, individuals can also experience a range of often perplexing digestive issues, especially during their periods. This can include persistent bloating, sometimes called endobelly, nausea, diarrhea, constipation, symptoms that can easily be confused with, or unfortunately even coexist with, conditions like irritable bowel syndrome or IBS.
Right, which makes diagnosis even trickier.
Exactly. It complicates both diagnosis and treatment significantly. And then there are more systemic, often insidious symptoms, such as debilitating fatigue or persistently low energy. This isn't just feeling a bit tired. It can drain overall vitality and profoundly impact a person's ability to function day to day. This widespread impact truly illustrates how endometriosis is far, far more than just bad period pain.
It really affects the whole body, the whole person. This chronic pain, the relentless struggle with diverse symptoms, and the deep uncertainty surrounding it all, unfortunately, takes a severe toll on mental well-being. It often leads to significant depression and anxiety, which is completely understandable given the circumstances. But here's where it gets truly complex and often incredibly frustrating for both patients and healthcare providers alike. The seriousness of your pain may not, surprisingly, be a reliable indicator of the number or the extent of endometriosis growths in your body. This is a critical paradox we need to understand.
It is indeed, host, a profound paradox. It creates immense challenges in diagnosis, and unfortunately often leads to patient invalidation, where people are told their pain can't be that bad because their scan looks normal. You can have a very small amount of tissue, maybe just a few tiny superficial lesions, with incredibly severe, life-altering pain that dominates your life. Conversely, some individuals can have extensive, widespread endometriosis tissue, what we'd classify as stage 4 disease, with deep infiltration and significant adhesions, yet experience surprisingly little or even no pain at all. This also accounts for the asymptomatic cases, where some people with endometriosis don't have any noticeable symptoms whatsoever.
And how are those usually found then?
Often, their condition is discovered incidentally during a surgery for another reason, perhaps removing an appendix or an ovarian cyst, or during an extensive infertility workup. It often comes as a complete shock.
Wow, so this incredible variability and the fact that endometriosis symptoms are variable and broad also means they're master mimics, right? They can closely resemble symptoms of other conditions like pelvic inflammatory disease, PID, ovarian cysts, or as we mentioned, irritable bowel syndrome, IBS. And to complicate matters further, IBS can and often does occur along with endometriosis. They can coexist. This creates a tangled web of symptoms that is incredibly challenging for clinicians to untangle, making it even harder to pinpoint the exact cause or causes of a person's chronic discomfort.
This mimicry and symptomatic overlap are, without a doubt, primary contributors to what we refer to as significant diagnostic delay. It's a huge problem. Because the symptoms aren't unique to endometriosis, healthcare workers, particularly at the primary care level, may not easily diagnose it. They might misattribute symptoms to other conditions, or worse, normalize severe pain, telling patients it's just part of being a woman. And Toko. Coupled with the fact that many individuals experiencing these symptoms may not be aware of the condition themselves, often accepting severe pain as their normal because they've never known anything different, it creates this perfect storm for years, sometimes even decades, of suffering before an accurate diagnosis is finally achieved.
Years, even decades, that's just staggering. So what does this accumulation of pain, varied symptoms, and diagnostic challenges ultimately mean for someone living with this day in, day out? The impact of endometriosis extends far, far beyond just physical pain. It can cause such debilitating pain that prevents them from going to work or school, forcing them to put careers on hold, maybe abandon educational pursuits, or constantly budget their limited energy, knowing that a flare-up could derail everything from a job interview to simply picking up groceries or playing with their kids. This isn't just discomfort, it's a fundamental restructuring of daily existence for millions, impacting their economic stability, social engagement, and future opportunities.
And the effects are incredibly intimate and personal, host. Painful sex due to endometriosis can lead to interruption or avoidance of intercourse and affect the sexual health of affected individuals and their partners. This creates significant strain, emotional distance, and a profound sense of loss within relationships. It's a topic that's often difficult to talk about, but it's a major issue. And this chronic nature of symptoms, coupled with the often lengthy and frustrating diagnostic challenges and the immense emotional weight of potential or actual fertility issues, profoundly contributes to increased rates of depression and anxiety. The mental and emotional toll is just as real and as debilitating as the physical pain itself.
Absolutely. And zooming out on a broader societal scale, endometriosis has significant social, public health, and economic implications. We're talking about billions lost annually in healthcare costs and lost productivity globally. Billions. not to mention the immeasurable toll on the quality of life for those 190 million people and their families. It's truly a silent global health crisis that reverberates through communities and economies.
Indeed. Recognizing the full spectrum of this burden is paramount. Addressing this condition effectively, from achieving early diagnosis to providing comprehensive multimodal treatment, is about empowering individuals, validating their experiences, and supporting their fundamental human right to the highest standard of sexual and reproductive health and overall well-being. It's really about systemic change that moves beyond simply treating symptoms to truly supporting lives impacted by this disease.
Given this incredibly wide range of variable symptoms and how they so frequently overlap with other conditions, getting an accurate diagnosis for endometriosis can truly be a long, arduous, and emotionally challenging journey for many people. The average diagnostic delay is alarmingly significant, often cited as 7 to 10 years globally, sometimes longer.
It's shocking, really.
It is. And this delay is largely attributed to a limited awareness of endometriosis among primary healthcare providers who may not immediately consider the condition, especially if symptoms are atypical. This is coupled with the normalization and stigmatization of symptoms by both patients themselves, who might think severe pain is normal, and unfortunately by parts of the medical community who might dismiss the pain.
The diagnostic journey, host. It fundamentally has to start with truly listening to the patient's story. A careful history of menstrual symptoms and chronic pelvic pain provides the essential basis for suspecting endometriosis. This initial conversation, where a clinician genuinely hears, believes, and validates a patient's pain and experience, is absolutely paramount. It builds trust and directs the investigation. Following that detailed history, a physical exam, specifically a pelvic exam, may be performed. During this, a provider might try to feel for cysts or scar tissue behind your uterus, or detect tenderness in specific areas, maybe nodules in the rectovaginal space. However, and this is crucial to understand, a normal physical exam does not rule out endometriosis. Many lesions, especially superficial ones, are too small or too diffuse to be felt manually.
Right, so a clear exam doesn't mean no endo. And what about imaging? You hear about ultrasounds and MRIs. Studies like ultrasonography or magnetic resonance imaging, MRI, can be incredibly useful to look for signs of endometriosis, particularly for the larger manifestations. Things like ovarian endometriomas, deep infiltrating endometriosis that might involve the bowel or bladder, or significant adhesions. Transvaginal ultrasounds, which use a small wand inserted to provide detailed views of reproductive organs, are often the first step. MRIs, using magnetic waves, give highly detailed images of soft tissues. They can offer crucial clues and definitely help guide treatment planning, especially for more advanced or complex cases.
They absolutely can be helpful, but a key limitation and a critical piece of information for anyone navigating these symptoms is that there is no lab test, procedure, or imaging that can definitively diagnose endometriosis without surgery. Let me repeat that. Imaging cannot definitively rule it out. These tools cannot accurately identify or predict individuals or populations that are most likely to have the disease with 100% certainty, especially for minimal or moderate disease. While they can strongly suggest endometriosis, particularly in more severe cases with endometriomas or deep nodules, they cannot definitively confirm its presence or, importantly, rule it out completely if the scan is normal. This means a negative imaging scan does not equate to an absence of the disease, a point often misunderstood by both patients and sometimes clinicians, leading to further delays.
Okay, so this brings us to the gold standard, the definitive diagnosis. And for many, this is another incredibly surprising and challenging aspect. It typically requires surgery. The gold standard for confirming endometriosis is a minimally invasive surgical procedure called a laparoscopy.
That's correct. During a laparoscopy, a surgeon makes a small incision, usually near the navel, sometimes a few others in the abdomen. They then insert a thin tube equipped with a light and a high-definition camera, laparoscope, to visualize inside the body, looking directly at the pelvic organs and peritoneum. The surgeon then meticulously evaluates for endometrial-like tissue on organs and structures within the pelvic cavity. They're looking for those characteristic lesions which can look like small black powder burns, red flame-like lesions, clear vesicles, white scars, or deeper nodules, as well as adhesions and any anatomical distortions. If any suspicious tissue is found, and this is the crucial step for definitive diagnosis, it is ideally removed, excised, and examined under the microscope by a pathologist to confirm the presence or absence of endometriosis. This histologic verification is absolutely required for a definitive diagnosis.
And you mentioned removal laparoscopy can be treatment too, right?
Yes, exactly. It serves a dual purpose. It's both diagnostic and therapeutic. Lesions found can often be removed or treated, excised or ablated during the same procedure, offering potential symptom relief.
And this necessity for surgery for a definitive diagnosis expert, that's a huge hurdle, isn't it? And often an incredible burden for patients. It's an invasive procedure. It comes with risks, recovery time, costs. And it can be emotionally and logistically draining for individuals already dealing with significant pain and uncertainty.
You've hit on a critical point, host. The requirement for surgery creates a significant barrier to timely diagnosis for many. While awaiting definitive surgical confirmation, especially when symptoms are severe and debilitating and surgical wait times might be long, it is crucial not to delay the commencement of empirical medical treatment. Sometimes starting hormonal therapy or aggressive pain management based on a strong clinical suspicion and patient history can offer much-needed relief and a chance to improve quality of life before a surgical diagnosis is formally made. It's about managing the symptoms proactively.
That makes sense. Treat the symptoms while waiting for the confirmation. Now, once endometriosis is definitively diagnosed, often via that laparoscopy, doctors often classify it into stages, right? Typically stage 1 to stage 4, based on things like the location, the extent of spread, the depth of infiltration, and the amount of tissue found during surgery.
Yes, the staging systems, like the revised ASRM classification, are used primarily to provide a standardized description of the surgical findings. Stage 1 is minimal, stage 4 is severe. However, and this is another one of those crucial counterintuitive insights about endometriosis, it's absolutely vital to remember that having a more advanced stage of endometriosis does not always mean you will have more severe symptoms or more pain.
There's that paradox again.
Yeah, exactly. It reinforces that perplexing variability we discussed earlier. Some women with extensive stage 4 endometriosis, widespread disease, large endometriomas, obliterated posterior cul-de-sac, might remarkably have few or even no symptoms. They might present primarily with infertility. While conversely, those with stage 1, characterized by just a few scattered superficial lesions, can experience absolutely severe life-altering pain that completely disrupts their lives. This disconnect between the objective surgical staging and the subjective experience of pain further complicates both diagnosis and a patient's journey. It makes it crystal clear that a higher stage doesn't necessarily mean a worse prognosis for pain, nor does a lower stage equate to less suffering. Each patient's experience is truly individual.
Okay, so once diagnosed, staged or not, the next crucial step is managing the condition. And it's important to understand upfront for all our listeners that currently no treatments cure the disease. This is a chronic condition. The focus of all interventions is squarely on controlling symptoms, alleviating pain, managing fertility goals, and ultimately improving the overall quality of life. This isn't about permanent eradication right now, unfortunately, but about achieving sustainable relief and functionality.
And because of this chronic nature and the individual variability, treatment can vary significantly based on the severity of symptoms and, crucially, whether pregnancy is desired. That's often a major deciding factor in the treatment path. Beyond that, individual preferences, the effectiveness of various options for that person, potential side effects, long-term safety profiles, costs, and local availability all play a significant role in determining the most appropriate and personalized treatment pathway. It really has to be a shared decision-making process between the patient and their physician, recognizing the diverse needs and goals of each individual living with endo.
Makes sense. So for managing the persistent pain, the first line of defense often involves widely available medications. Things like non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen and naproxen, along with other general analgesics or painkillers. These are frequently recommended to help reduce inflammation and alleviate discomfort, especially around menstrual periods.
Yes, they target the inflammatory component. But beyond conventional pharmaceuticals, for some patients, especially those experiencing secondary changes in the pelvis like pelvic floor muscle dysfunction, spasms or trigger points, or those who develop central sensitization, where the nervous system itself becomes over-responsive to pain signals, physiotherapy and complementary treatments can also provide significant benefits.
Like what kind of things?
This might include modalities like acupuncture, TNS, transcutaneous electrical nerve stimulation units, or specialized pelvic floor physical therapy, which is often incredibly helpful. These therapies aim to address the broader impact of chronic pain on the musculoskeletal system and nervous system. They often work synergistically with medical or surgical treatments to improve overall function, reduce pain, and enhance quality of life.
Right, looking beyond just the lesions themselves. And then we move into the realm of hormonal therapies, which play a particularly significant role in managing endometriosis. These treatments, as I understand it, are designed to alter hormone levels or suppress the menstrual cycle, directly targeting the estrogen-dependent nature of the disease. Basically, starting those endometrial-like lesions of the fuel they need to grow and cause inflammation.
That's exactly right, host. You're manipulating the hormonal environment. One common and accessible approach involves various contraceptive methods. These include options like combined birth control pills, progestin-only pills, hormonal IUDs like Mirena, the vaginal ring, Nuvaring, implants, Nextirainen, injections, Depo-Provera, and patches. These hormonal contraceptives, whether they're combination estrogen, progestin, or progestin-only, work primarily by suppressing ovulation and significantly reducing the monthly hormonal fluctuations that stimulate endometrial growth and bleeding. This can help control pain and often leads to lighter, less painful, or even absent periods by essentially putting the reproductive system into a more quiescent, stable state. They can be used continuously to avoid periods altogether. Okay, so that's one category. What else is there hormonally? Well, another class of powerful medications are the GnRH analogs, gonadotropin-releasing hormone analogs. These include GnRH antagonists like elagolix or Lisa or relugolix, or GnRH agonists like Leuprolide, Lupron, or Goserelin, Zoladex. These medications work differently, but the end result is profound suppression of the pituitary gland's release of hormones, FSH and LH, that stimulate the ovaries to produce estrogen. In essence, they stop the hormones that cause your menstrual cycle, effectively putting your reproductive system on hold into a temporary, medically induced menopause-like state. While highly effective at relieving pain for many, these can come with significant menopausal side effects like hot flashes and bone density loss, so they're often used for limited durations, sometimes with add-back therapy, low-dose estrogen progestin to manage side effects.
Right, that menopause effect is a big consideration.
Absolutely. And then we also have older hormonal medications like danazol, Danacrin. This is a synthetic steroid with androgenic properties. It works by suppressing pituitary hormones and directly inhibiting enzymes involved in estrogen production. This stops the production of hormones that cause periods, often leading to occasional or even completely stopped menstruation, providing significant relief from symptoms for some. But it also has androgenic side effects like acne or weight gain that limit its use nowadays compared to newer options.
So several different hormonal angles to try, but it's a crucial consideration with all these hormonal treatments, isn't it, that these methods may not be suitable for those wanting to get pregnant as they directly affect ovulation and prevent conception while being used.
Precisely, that's the fundamental trade-off.
And it's also important for listeners to understand the chronic nature of this management. Symptoms can, and often do, come back if you stop taking the medication. These aren't cures, they are long-term management strategies for symptom control.
Exactly. They suppress the disease activity while you take them, but they don't eliminate the underlying potential for it to return once the treatment stops.
Okay, let's shift to surgical interventions. These treatments aim for the direct removal or destruction of the problematic tissue itself. Laparoscopic surgery, as we discussed for diagnosis, is also a key treatment procedure here. Its primary purpose, therapeutically, is to remove endometriosis lesions, adhesions, and scar tissues.
Correct. This can involve excision, where the tissue is carefully cut out and removed, which is generally preferred, especially for deeper lesions, as it allows for histological confirmation and aims for complete removal. Or it can involve ablation, where tissues are destroyed using heat, laser, or electrical energy. Ablation might be quicker for superficial lesions, but carries a risk of incomplete treatment for deeper disease and doesn't provide tissue for pathology. The choice depends on the surgeon's skill, the location and type of lesions, and patient factors.
And the benefits of laparoscopy are significant, right? It's minimally invasive, meaning small incisions, generally shorter recovery time compared to traditional open surgery, laparotomy. And it can provide incredibly significant relief from pain and potentially improve fertility for many individuals. However, here's that crucial nuance again. Lesions may recur even after successful eradication, and sadly, the pain may come back within a few years for a significant number of patients, maybe 40–50% within 5 years, depending on the study and severity. So it's often not a permanent fix, but rather a vital component of a long-term management plan, maybe followed by hormonal suppression to delay recurrence.
That's a very accurate summary. And the complexity of these surgeries can be quite high, host, especially for deep infiltrating endometriosis, involving organs like the bowel, bladder, or ureters. Depending on the location and depth of the disease, some procedures may require a team of surgeons with specialized skills. perhaps a minimally invasive gynecologic surgeon working alongside a colorectal surgeon if the bowel is significantly involved, or a urologist if the bladder or ureters need dissection. This multidisciplinary approach ensures all affected areas are addressed safely and effectively, minimizing residual disease and potential complications.
Right, it can get very complex surgically, and in particularly extensive cases, or maybe for individuals who aren't candidates for laparoscopy, is a laparotomy, a larger open incision, still sometimes used.
It might be necessary in very rare complex situations or if laparoscopic expertise isn't available, but it's becoming increasingly less common for endometriosis treatment due to the advantages of minimally invasive approaches.
Okay. And then, as a more extreme and often final measure in really severe cases, particularly if other treatments have failed miserably, if pain is completely intractable and ruining quality of life, or if pregnancy is definitively not desired, the surgical removal of the uterus, hysterectomy, and/or the ovaries, oophorectomy, may be suggested. This feels like a profound decision, not taken lightly at all.
Indeed, host, it is a truly significant and irreversible decision, especially the oophorectomy part. Removing the ovaries, the oophorectomy, will stop the release of hormones and should definitively treat endometriosis in most cases by significantly lowering estrogen levels and slowing or stopping endometrial tissue growth. By removing the primary source of estrogen, you essentially cut off the fuel supply to any remaining lesions.
But that trade-off.
It's a major trade-off, yes. Because removing the ovaries surgically induces menopause, often abruptly, especially in younger women. This brings with it a range of potential risks and side effects that must be carefully considered and discussed. Hot flashes, accelerated bone loss leading to osteoporosis, increased risk of heart disease, vaginal dryness, decreased sexual desire, potential memory problems, and a higher risk of depression or anxiety. So it is a significant decision made between the patient and their physician based on case-specific factors and the patient's personal goals, particularly because a hysterectomy means no future pregnancies and oophorectomy brings on menopause. The decision on whether to remove the ovaries at the time of hysterectomy for endo is complex and very individualized.
A huge decision. Now, for those who do desire pregnancy and are struggling with difficulty conceiving due to endometriosis, there are dedicated fertility treatments and considerations. Options can include that laparoscopic surgical removal of endometriosis, where the surgeon aims to remove lesions that might be blocking fallopian tubes or causing inflammation impacting egg quality or implantation. What else?
Other medical interventions can include ovarian stimulation with intrauterine insemination, IUI, where fertility drugs are used to stimulate egg production, followed by placing sperm directly into the uterus. And of course, in vitro fertilization, IVF, which bypasses many of the physical barriers created by endometriosis by fertilizing eggs with sperm in the lab and transferring the resulting embryo directly into the uterus. IVF often offers the highest success rates for moderate to severe endo-related infertility. However, it's incredibly important to counsel patients that success rates vary greatly depending on the individual's specific case, their age, the severity of the disease, ovarian reserve, partner factors, and other contributing fertility issues. It's not a guaranteed solution.
And what about preserving fertility if someone needs, say, an oophorectomy but might want kids later?
That's a critical conversation. For individuals facing potentially fertility-damaging treatments like oophorectomy, fertility preservation options should absolutely be discussed beforehand if possible. This might include harvesting and cryopreserving, freezing eggs, or embryos before surgery for future use with IVF. These are absolutely critical conversations that underscore patient autonomy and the comprehensive planning required when managing endometriosis, particularly for younger patients facing difficult treatment choices.
Good to know those options exist. Ultimately, as we've highlighted repeatedly throughout this dive, endometriosis is a chronic disease. This isn't something you treat once and it's gone forever, usually. This means it requires ongoing attention and a strategic approach to long-term management. It's crucial for anyone affected to be maintaining a regular appointment schedule with your healthcare provider for ongoing monitoring, symptom assessment, and adjustment of treatment plans as needed over time.
Absolutely. Proactive engagement and long-term management is key. We know that enhanced awareness, followed by early diagnosis and effective management, may slow or halt the natural progression of the disease in some cases. This proactive approach has the potential to significantly reduce the long-term burden of symptoms, prevent the development of severe complications like dense adhesions or organ damage, and ultimately profoundly improve the quality of life for those living with this challenging condition. It's really about staying ahead of the disease whenever possible, not just reacting to flare-ups.
Okay, looking ahead now. Despite the available treatments and the incredible advances in research, the journey with endometriosis is still fraught with significant challenges, especially when we look at the global landscape. From the perspective of organizations like the World Health Organization, a major hurdle remains a profound awareness gap, just basic awareness. In many countries, the general public and most frontline healthcare providers are simply not aware that distressing and life-altering pelvic pain is not normal. This seems unbelievable, but it's true. This leads to that widespread normalization of severe symptoms and, as we've discussed, those heartbreaking years-long diagnostic delays.
Adding to this host, there's a pervasive limited capacity of health systems for specialized surgical interventions, particularly prevalent in low and middle-income countries, but even in wealthier nations, access can be patchy. This lack of access to highly skilled excision surgeons and appropriately equipped facilities is compounded by a lack of multidisciplinary teams. Those teams involving gynecologists, colorectal surgeons, urologists, pain specialists, physical therapists that possess the diverse skills needed for early, comprehensive diagnosis and effective treatment of complex endometriosis cases. These systemic issues mean that countless patients struggle to access the timely, appropriate care they desperately need, further exacerbating their suffering and disability.
And another critical ongoing challenge is the lack of effective and crucially non-invasive diagnostic tools. Tools to screen and accurately predict patients and populations who are most likely to have the disease are still lacking, forcing us to rely on invasive surgical methods for definitive confirmation, which, as we discussed, is a major barrier.
Exactly. And in terms of treatment, there remains a significant need for non-invasive diagnostic methods, as well as medical treatments that do not prevent pregnancy. End quote. We need better ways to diagnose without surgery, and we need more effective medical options that manage symptoms effectively without suppressing fertility, addressing that critical desire for pregnancy for many affected individuals and offering more gentle, patient-friendly, long-term options.
So where is the focus now for organizations trying to tackle this?
Addressing these multifaceted issues is the current, urgent focus of the global endometriosis response. Organizations like the WHO and many patient advocacy groups and research foundations are actively involved in fostering international partnerships for research, looking for biomarkers for diagnosis, exploring novel non-hormonal treatment targets. They're also advocating for increased awareness campaigns, both public and professional, and promoting the adoption of effective national policies and clinical guidelines to improve standards of care worldwide. The goal is really to move towards a future where diagnosis is swift, treatment is accessible and tailored, and the burden of this disease is significantly lessened.
That's encouraging. Now, while we still grapple with the exact cause of endometriosis, research has done a pretty remarkable job in identifying several factors that can significantly increase your risk of developing it. What are some of those? Factors like never having given birth seem to increase risk. Starting periods at a particularly early age, typically before age 11, or conversely, going through menopause at an older age.
Right. Those relate to lifetime estrogen exposure. Starting periods early or going through menopause late essentially means a longer duration of exposure to cyclical estrogen, which, as we know, fuels endometriosis growth.
Other recognized risk factors include having consistently short menstrual cycles, for example, less than 27 days between periods.
Which means more frequent menstrual events, potentially increasing opportunities for retrograde menstruation or inflammation.
Or experiencing heavy menstrual periods that last longer than 7 or 8 days. Higher levels of estrogen in the body generally, or greater lifetime exposure to estrogen from various sources are also key risk factors. Interestingly, a low body mass index, BMI, has also been correlated with an increased risk in some studies, though the exact mechanism there is still being investigated, might relate to metabolic or hormonal differences.
It's a complex relationship, and a very significant factor is a family history of endometriosis. If your mother, aunt, or sister has it, your risk is definitely elevated, maybe 7 to 10 times higher, pointing strongly towards a genetic component. Those specific genes are still being mapped out. And as mentioned before, any health condition or structural issue with the reproductive tract that physically prevents or obstructs menstrual blood from flowing out of the body during periods can also significantly increase susceptibility by forcing more retrograde flow. Okay, so those increase risk. Conversely, are there factors that might lower your risk? Things like pregnancy and breastfeeding seem protective, is that right? Yes, these periods naturally suppress ovulation and menstruation, creating a lower estrogen, higher progesterone state, which is unfavorable for endometriosis growth and can even cause existing lesions to regress temporarily. It reduces the overall exposure to those cyclical hormonal fluctuations.
Also, having your first period after age 14 is associated with a lower risk, again, likely due to a shorter lifetime exposure to estrogen overall. And here's that surprising insight again from some research that adds another fascinating layer. Eating fruits, especially citrus fruits, has been tentatively linked in some epidemiological studies to a potentially lower risk.
That finding about citrus fruits is definitely an interesting one, host, and often gets attention. It highlights the potential role of dietary factors in inflammation. While much more research is needed to confirm this and understand the mechanism, the hypothesis is that the high levels of antioxidants, particularly flavonoids like hesperin and naringenin found abundantly in citrus fruits, may possess anti-inflammatory properties. These might potentially mitigate some of the chronic inflammatory processes that are so central to endometriosis development and progression.
Interesting, but still needs more study.
Absolutely. It's an association, not proven causation. And while these risk factors and potential protective factors are useful for understanding population trends and guiding further research, it is absolutely crucial to reiterate for our listeners that at present, there is no known way to prevent endometriosis. You can't control when you start your period or if your sister has it. Our focus, therefore, remains squarely on early recognition of symptoms, prompt diagnosis, and effective individualized management to minimize its impact on health and quality of life.
Right. Prevention isn't on the table yet. Okay. Beyond the persistent pain and the significant challenges to fertility, endometriosis can lead to other serious complications over time. As we've mentioned several times, infertility remains the main complication, affecting up to half of people with endometriosis. That's a huge percentage.
It is. The mechanisms are varied and complex. Endo can physically block fallopian tubes with adhesions or distort pelvic anatomy. The chronic inflammation within the pelvis can create a hostile environment that damages sperm or egg quality. It might also affect the uterine lining's receptivity for embryo implantation, even if fertilization occurs.
And this is why healthcare professionals sometimes advise those with endometriosis not to delay having children if pregnancy is desired, correct? Because the condition may unfortunately worsen over time, making conception progressively more challenging.
That conversation definitely happens, balancing personal life choices with the potential progression of the disease and its impact on fertility. It's a delicate discussion.
And it's vital to address the conversation around cancer risk, as this is a common concern and source of anxiety for patients when they get diagnosed. While some studies suggest that endometriosis raises the risk of certain types of ovarian cancer, specifically endometrioid and clear cell types, it's crucial to put this into appropriate context.
Yes, context is key here. The overall lifetime risk of ovarian cancer for the general population is already low to begin with, around 1.3%, and it stays fairly low in people with endometriosis. While the relative risk might be slightly increased, maybe 1.5 to 2 times, the absolute risk remains small for most individuals. So while there might be a very slight statistical increase, it doesn't warrant routine ovarian cancer screening beyond standard care, nor prophylactic ovary removal just because of endo, unless other risk factors are present.
Okay, that's reassuring context. However, you mentioned another type?
Yes, it's worth noting that a very rare type of cancer called endometriosis-associated adenocarcinoma can, in infrequent instances, happen later in life, usually rising from pre-existing endometrial lesions, particularly within ovarian endometriomas or deep infiltrating nodules. This is very rare, but it underscores the rationale for removing suspicious lesions, especially endometriomas, and the need for ongoing gynecological monitoring, even after menopause in some cases.
Got it. And as we touched on earlier with the rarer locations of growth, other complications can include significant bowel or bladder problems, things like blood in your pee or poop, hematuria or hematochezia, especially cyclically with periods, or intense agonizing pain when using the bathroom, particularly during menstruation, if those organs are deeply infiltrated by endotissue. It can even cause bowel obstruction in severe cases.
Exactly. And if the lungs or diaphragm are impacted, though this is uncommon, individuals can experience those distressing symptoms like shortness of breath or chest pain, sometimes even a collapsed lung. catamenial pneumothorax, that are often initially mistaken for primary pulmonary or cardiac conditions.
It really can affect so many systems. Ultimately, expert living with endometriosis can profoundly impact your life, touching every dimension physically, emotionally, socially, professionally. It's exhausting. Dealing with endometriosis, its persistent pain, its potential complications like infertility, and the often heartbreaking fertility problems can be incredibly hard to cope with and be immensely stressful.
Absolutely. The chronic, unpredictable nature of the disease demands incredible resilience and constant adaptation. This is precisely why support is so vital. We strongly encourage anyone affected, or anyone supporting someone with endo, to consider joining a support group of people who can genuinely relate to what you are going through. Shared experience is powerful. Local patient support groups, numerous online communities, and dedicated charities can offer invaluable additional advice and emotional assistance, a sense of community, validation, practical tips, and a shared understanding that can be incredibly empowering and reduce feelings of isolation.
That support network sounds crucial. And so, we come towards the end of our deep dive into endometriosis. We've journeyed through the complexities of this chronic condition where uterine-like tissue grows outside the uterus, profoundly affecting an estimated 190 million people worldwide, that's 1 in 10. We've explored the diverse and still, frankly, mysterious theories about its origins, from retrograde flow to stem cells. We've navigated the often debilitating and incredibly variable symptoms, particularly the pain that goes far beyond normal. We examine the complex diagnostic journey that frequently requires surgery for confirmation after often long delays. And we discuss the current range of management strategies, hormonal, surgical, supportive, all aimed at improving quality of life, not offering a cure just yet.
And while that absence of a definitive cure remains a significant challenge, understanding the disease in its full complexity, its biological mechanisms, its variable presentations, its profound systemic impact is the essential first step. It's the foundation for better management, for effective advocacy, and ultimately for improved patient outcomes. It's a condition marked by significant biological intricacy and an individual experience that varies so widely from person to person. This truly emphasizes the critical importance of personalized care, active listening by clinicians, and a comprehensive, compassionate, multidisciplinary approach.
Absolutely. And what stands out to you, the listener, from today's deep dive is I really hope the profound and undeniable message that severe, life-altering pelvic pain is not normal. Despite how often it's been normalized, dismissed, or stigmatized for generations, it's just not acceptable. This raises a crucial and, I think, provocative question for all of us to consider. How can we collectively shift the narrative, not just around endometriosis, but indeed around all chronic pain, especially pain predominantly affecting women? How do we ensure that every individual's experience of pain is not just heard, but truly believed, validated, and addressed promptly and comprehensively, rather than being dismissed for years on end, leading to so much unnecessary suffering and loss?
That shift in perspective, host, has the power to truly empower you or those you know. Empower you to become proactive advocates for your own health or the health of loved ones, to challenge diagnostic delays with informed questions, to push back against dismissal, and to actively seek comprehensive support from knowledgeable healthcare providers and dedicated patient communities. It's about recognizing that persistent, life-disrupting pain demands investigation and compassionate, thorough care. It's about moving away from a culture of silence and shame around menstrual health and pelvic pain towards one of open dialogue, belief, effective action.
Well said. So if you suspect you or someone you care about has symptoms of endometriosis, please talk to your healthcare provider. Don't dismiss your pain or let others dismiss it. Remember, you're not alone, far from it. And resources like patient support groups exist to provide vital connection, information, and emotional assistance. Continued learning and awareness for patients, for providers, for the public are truly a powerful pathway to earlier diagnosis and, ultimately, a significantly improved quality of life for those living with this challenging condition. Thank you for joining us on The Deep Dive.